Good morning. My name is Chad Worley of Lurie Children's Hospital. I am the physician liaison for the north suburbs as well as the north side of the city. And I just want to welcome you to our pediatric epilepsy roundtable that we're hosting throughout the day today. We are going to have sessions today at 7:30, 9 a.m., 12 p.m., 3 p.m., and 5 p.m. And we are running the gamut from seizures to EEGs, to ketogenic diets, epilepsy surgery, and we're here this morning for pediatric epilepsy from Dr. Tatachar. She is our attending physician for neurology and epilepsy center. She has clinical interests and programs that she is in, like neurology, the epilepsy tuberculosis sclerosis clinic, tongue-tied for me, epilepsy program, and she sees patients at the main hospital. And as we go on throughout after her presentation, I'll have a slide up for you all so you can see what her contact information is. But without further ado, why don't I just go ahead and send it over to Dr. Tatachar, and she'll go ahead and introduce herself and start her presentation. So you are now you should be now in presentation mode there, and I'm going to go ahead and get off camera.
Good morning, everyone, and thank you for joining. This is way early in the morning, but I appreciate you joining us. Let me put this in presentation mode, and we can get started. Okay, so my name is Tatachar. I'm one of the attending physicians at Lurie Children's Hospital. My special interests are epilepsy, tuberous sclerosis, and epilepsy surgery. This is a rather large topic, and I'm trying to see how much we can get an overview of in the next 15 to 20 minutes. I will be using videos, and the videos have been used with permission of the parents. So because it's a rather large topic, I'm trying to concise it to understanding the definition of seizures and epilepsy. What is the current classification that we're using? What are the common syndromes that we see, and what are some of those mimics of epilepsy, and how is generally the workup done for epilepsy per se, and an overview of the management as you will follow through with different discussions throughout the course of the day. So let's start with what is epilepsy. Epilepsy is a disorder of the brain. It is one of the most common disorders affecting children. In current estimates, about 4 to 10 per 1,000 people are estimated to have active epilepsy. 1 in 25 people will have a seizure in the course of their lifetime. That's pretty common and a large burden that we're seeing in the country. In our country itself, we have over 400 million, so almost 500,000 children reported to have active epilepsy. Among the 5 conditions, chronic conditions that you probably see in your clinic, epilepsy is the second most common, and it's actually one of the costliest, second to asthma, in terms of healthcare utilization, in terms of neurological conditions. So what is epilepsy and what is a seizure? Think of it like asthma and a wheezing attack. A seizure is sort of similar to a wheezing attack. So it is an occurrence of symptoms that is secondary to an abnormal, excessive, and synchronous discharge of the brain. It is essentially the event. The event of a seizure doesn't mean that the patient has epilepsy. A seizure is actually, it's been derived from Greek. It goes back to biblical times where people thought that this was secondary to the devil taking over the body. So it means to seize from within, so or possessed from within. That's what a seizure actually means. Seizures can be due to many, many conditions, and not necessarily primarily the disorder of the brain. It can be secondary to hypoxia, where there is less oxygen delivery to the brain, as occurs in a lot of infants and neonates during birth. It can be due to electrolyte disturbances. It could be due to infections, which is a very common cause of seizures, encephalopathies, head traumas, febrile illnesses, which is very commonly seen in pediatric clinics, metabolic or toxic conditions, space-occupying lesions like tumors, and more commonly in the adults, alcohol withdrawal, drug withdrawal, strokes, cerebrovascular accidents, and in pregnancy, eclampsia is a very common cause of seizures. These seizures are called provoked seizures because the brain is sort of responding to an environmental disturbance, and it's not intrinsically a brain disorder. Whereas epilepsy is a disorder of the brain. It's characterized by a predisposition of the brain itself to generate seizures. And this could be because of many conditions that are affecting the brain milieu. And the consequences of this is called epilepsy syndrome or an epilepsy disorder. To have epilepsy, the patient must have at least one epileptic seizure and the potential to develop more in the future. So because of all of the confusion, the ILAE or International League Against Epilepsy went ahead and gave out a practical definition. So what is a practical definition of epilepsy? Two unprovoked or reflex seizures occurring more than 24 hours apart. What is a reflex seizure? People who have seizures secondary to certain triggers. For example, people who have epilepsy when they have photosensitivity, when they go to movies that have flashing lights, that's a reflex epilepsy. So having two or more of these unprovoked seizure, stereotypic in nature, they look pretty much the same from one to the other, or having one of such seizures, but just looking at the patient's history that there is a high probability of having a second one. If you have two, then your recurrence risk of having epilepsy or further seizures is at least 60%. So having one seizure with a probability of 60% further down the line, or having two unprovoked seizures which are 24 hours apart constitutes epilepsy. And of course, if there is an epilepsy syndrome that's identified as a part of genetic studies or MRI studies as a part of the overall clinical picture, it's a part of an epilepsy syndrome like Dravet syndrome, and we will talk about that. Seizures can be coming from one part of the brain or can be, essentially involve the entire brain, or sometimes can start somewhere and when you find the patient may have involved the entire brain. So we call it focal onset seizures, generalized onset seizures, and sometimes unknown. ILAE classified seizures in 2017 as focal onset, generalized onset, and unknown onset. They went on to talk about etiology, which can thereby cause seizures as a primary part of a brain disorder. It could be a structural abnormality in the brain. It could be a genetic condition that is affecting the child. It can be an infectious cause like congenital CMV, congenital toxo. It can be a metabolic condition like inborn errors of metabolism. It can be an immune-mediated disorder like autoimmune encephalitis. And in most cases, it could be most often cryptogenic or unknown cause or etiological cause of epilepsy. We put that and then talk about epilepsy types. Is this a focal epilepsy type? Is this predominantly a generalized epilepsy type? Or is there a combination of both focal seizures and generalized seizures? Or at some point, we are not sure. And then we come together and put it together as an epilepsy syndrome. For example, I deal with patients who have tuberous sclerosis. Tuberous sclerosis is a genetic condition caused by a mutation either in chromosome 16 or chromosome 9. It is transmitted as an autosomal dominant condition passed on to 50% of the offspring. About 70% of these cases can occur as de novo mutations. But when they are transmitted, are inherited as autosomal dominant. What happens in this condition is that because of this genetic mutation, there are cortical tubers or hamartomas in the brain. So when you have a child that comes in, most common cause of infantile spasms in a genetic etiology is tuberous sclerosis. So we put all of that together. So in a child with tuberous sclerosis, you have infantile spasms, which are a generalized onset seizures, could be asymmetric spasms, then it could be a focal onset seizures. So they could also have focal epilepsy. So this is a patient that has combined general and focal epilepsy types. The etiology is a genetic etiology as well as a structural etiology because of the cortical tubers. When you look at the MRI and you see this picture and you make a diagnosis of definite tuberous sclerosis, you put that across as an epilepsy syndrome, epilepsy secondary to tuberous sclerosis complex. And the last thing to remember is to add in comorbidities that are seen in such syndromes. For example, ADHD, mood disorder, autism. These are all comorbidities that exist within the bracket of tuberous sclerosis. So that kind of makes it a tight diagnosis, and that is how we come about a diagnosis of epilepsy syndromes. Generalized epilepsies, this is a cartoon to show that it occurs at some point, but what happens is it's like a forest fire that just completely spread to the whole part of the brain, and there are bilaterally distributed networks that are engaged, subcortical networks are engaged as well. And this is the seizure that was previously called as grand mal seizures and are not called that anymore. So essentially, they start somewhere, either in one place, and rapidly involve the entire brain. Essentially, it's an excessive electrical distribution that occurs in the brain without the fusing mechanisms, coming into play. In terms of focal seizures, in a similar concept, this MRI is showing a mesial temporal sclerosis, and you can see that it starts in one hemisphere, in the temporal lobe of the right hemisphere. The seizure may progress to the neocortical area of the same temporal lobe and cause signs and symptoms that are seen with temporal lobe epilepsy, or they can even go across to the opposite temporal lobe, and you can even see other areas of the brain being involved, including the frontal, including the orbitofrontal, in the same seizure. So this is a focal seizure that is either limited to one part of the brain or involves limited networks in the brain. I have a few videos. These are common epilepsy syndromes that are seen in clinics. This is a very common type of epilepsy that you will see in clinics, and you can bring about by hyperventilation. This is a 7-year-old girl. The complaints are poor school performance, daydreaming, inattentiveness. And you can see with hyperventilation, there is a brief loss of awareness. The eyes roll up, and she's kind of stops doing what she's doing, and then she's back to baseline. This is a typical childhood absence epilepsy accompanied by a 3 per second spike wave discharges on the EEG behind her. This is a very common type of epilepsy seen in adolescents. Starts out as myoclonic jerks, typically early in the morning when they drop their toothbrush or the glass of coffee. They go on to a tonic portion where there is a tight dystonic posturing of the arms. There is also a sort of arching of the back. The back is tight and opistotonic in this particular picture, followed by clonic or rhythmic movements of the upper extremity. This is the clonic portion of her seizure. Increases in frequency. The clonic movements increase in frequency. You can also see the lower extremities having clonic movements. Does not appear that she is responsive or awake or alert at this point. She is completely unresponsive. And then it slowly waxes, wanes, and stops. This particular seizure is a generalized seizure with initially myoclonic and then tonic-clonic movements. This seizure typically was called a grand mal seizure and now is called generalized clonic tonic or tonic-clonic seizures, depending on what came first. In this particular event, there is a 15-year-old normally developing boy who motions to his mother that he's having a feeling that he's getting a seizure, or what we call as an aura. Following this, he leans back in his chair. He has a very scared look on his face. Doesn't seem like he's recognizing his mother. And then you can start to see abnormal movements of his mouth, like lip smacking. You can see drooling that he will have, basically unresponsive to the technician. He's still semi-aware. He's not unconscious, but he's not engaging with his surroundings. At this point, there is motor component where there is a head turn to the left, his eyes are rotated to the left, and then his body completely turns over. He is unaware of his surroundings, and he is not responding to mother. This particular type of seizure was caused because he had a right-sided temporal lesion. This is a focal seizure with impaired awareness, and you can see automatisms and mouth movements in the beginning of the seizure. This is a typical temporal lobe epilepsy, and that was the cessation of his seizure. So this is a focal seizure as compared to the previous one. And this particular one is also important to recognize in offices when children or parents show you videos. This is a 6-month-old baby. That was one exaggerated jerk that is a diagnostic of infantile spasms. That's another one. They have a startle sort of seizures. They occur in clusters, usually upon awakening from a nap or sleep, and they tend to occur with some discomfort to the child. And you will have a talk on infantile spasms with more details to follow on how to recognize this. For us, this is an emergency to treat to make sure that there is no lasting cognitive disability to the child. So we looked at some seizures. There is a lot of movements out there that can be scary to the family and can be very confusing to the pediatrician when they evaluate them for seizures. One of these can be in neonates, they have a jittery leg or arm movement. This is called benign sleep myoclonus. It's usually self-limited and goes away when the child grows up. It can happen in older children when they're either falling asleep or in their light stages of sleep. Vasovagal syncope is commonly seen as well, concerning for a drop seizure. History is very important. Over the past year, due to COVID, we've seen a lot of emotional and behavioral trauma to children. We're seeing a lot of psychogenic non-epileptic events. These are usually very hard to differentiate from true epileptic seizures. To remember that these are usually non-rhythmic jerks and do not follow anatomical, or physiological movements. They can be jerky, they can be non-rhythmic, they can be gyratory, and patient may be able to talk throughout these events, and they may not always be the same exact paroxysmal event. Breath holding spells can be very scary to the family, especially if they are cyanotic breath holding spells. Parasomnias, night terrors. Most common causes of EEGs are in babies that have apneas, bradycardias, opistotonic posturing due to Sandifer syndrome, or a I think it was called Brui, but I'm not sure what it's called anymore because the names keep changing. That was one of the side of important differential diagnosis for epilepsy in the first year of life. Migraine disorders, especially hemiplegic migraines, movement disorders, specifically tics, perioral tics, stereotypies, and dystonic movements are important paroxysmal events to differentiate from seizures. And in the adults, transient ischemic attacks, and even in older children with vascular malformations is something to think about. Most important thing to recognize is this really a seizure or not? And most importantly, is still history is key to our diagnosis. EEG is not a mandatory test and is not diagnostic. History and a documented witness event is more important than doing an EEG at a later date. To identify, we ask about premonitory symptoms, the ictal phase, what is the detailed description of the seizure itself, what did the post-ictal phase look like, and were there other spells, and if the patient had associated tongue biting, incontinence, or abnormal behavioral movements associated with the seizure. We look at the baseline exam, and it's important to note that some kids who have underlying neurological conditions, either autism, CP, developmental delays, are more at risk for developing seizures. So it also makes a difference if this child has a normal or an abnormal baseline neurological exam. When we do see a patient with a suspected new onset seizure, how do we work them up? Like we discussed, do the first due diligence history and witness accounts examination. And once we do this, if this is something acute, if there are focal neurological signs that are concerning, if there is fever, or if there has been a change in the developmental status of the child, we have to make a decision. Is this urgent enough to be evaluated in the emergency room concerning for meningitis, encephalitis, other kind of acute neurological disorders? We, either need a urgent CT scan to rule out a space occupying lesion, or can it be a more subacute process that we can have a good evaluation as an outpatient? So that's the important workup that we send a patient to either the ER for lab testing, or we send the patient to a neurologist where you think that this patient may have been having seizures at this point, and then let's get an MRI, let's get an EEG if necessary, depending on what we find, and then we move on to other management. We do the EEG, we do the MRI, and we get metabolic and genetic testing as indicated. We devise a diagnostic and therapeutic plan for this child. Once we have the plan, it's either a self-limiting epilepsy, like a childhood absence epilepsy that is age dependent and the child grows over it, or this is a well-controlled epilepsy. We're managing the child on anti-epileptic medications, have had good control with seizures. Or this is an intractable epilepsy, meaning the child has failed 2 or more well-selected and tried anti-epileptic medications. So when we have that kind of epilepsy, if there is a possibility, we start to look for surgical options for that child if that is a drug-resistant intractable epilepsy. So this is an overview of the workup for epilepsy. One of the more common conditions that is witnessed in childhood is febrile seizures. These are scary. These are, worrisome to the family, and most often to the physician and the pediatrician as well, because we have to make a decision. Is this going to go the LP route and the meningitic route, or is this a self-limited febrile seizure? Febrile seizures are very common. They're seen about in 2 to 5% of children between 6 months and 6 years of age. We can classify them as simple febrile seizures, which is usually a generalized tonic-clonic seizure that occurs, during the period of febrile illness and never repeats. That was it. They had a seizure and that's it. Versus complex febrile seizure, where it's a prolonged seizure longer than 15 minutes. It has focal features, meaning it is either a seizure preceded by one arm jerking, one leg jerking, eye deviation, or there's repeated seizures within a course of 24 hours. So most seizures are simple febrile seizures. Complex febrile seizures tend to occur and tend to repeat. So how many of these kids will go on to have more seizures? About 33% of children with febrile seizures will have a recurrence. Now, if they are younger when they started having febrile seizures, the chance of recurrence is more because they have a longer period for them to have fever and for them to have seizures. Fever, daycare attendance, and other illnesses can increase the risk of febrile seizures. There is a known family history, which is seen in patients with febrile seizures as well. To note that there is really no increased risk of epilepsy in patients who have febrile seizures who have no risk factors. In patients who have risk factors, meaning complex febrile seizures, they have a pre-existing neurological condition, and there is a family history of epilepsy, there is an increased risk of developing epilepsy. When do we refer to get more workup? If this is a complex febrile seizure or a recurrent febrile seizure, we think this could have a genetic etiology, and then we do workup for that child. If there is a prolonged hemiconvulsive febrile seizure or febrile status, and then the child goes on to have afebrile seizures, the one condition we have to think about and refer is Dravet syndrome. Dravet syndrome is a genetic condition, and this is a condition that starts out with prolonged hemiconvulsive febrile seizures, go on to have afebrile seizures, and then to have developmental regression and other developmental epileptic encephalopathy syndrome. So if you have patients that have concern, need to be referred to a specialist. So how do we manage epilepsy? Our mainstay of treatment is anti-epileptic medication. We have about 32 FDA-approved therapies. In a well-chosen manner, we first deduce what kind of an epilepsy syndrome it is, what kind of seizures are involved in this epilepsy, and thereby make therapeutic management. There are other non-pharmacological management, including dietary therapy, which you will hear about later. Surgical therapy, which could be a resective surgery if there is a space-occupying lesion or a focal cortical dysplasia, or palliative surgery in patients who have, Lennox-Gastaut syndrome or intractable epilepsy. We can also offer now neuromodulation, which is a vagal nerve stimulator or a reactive neurostimulator or a deep brain stimulator, although the RNS and DBS are not FDA approved yet, and we are looking to see if they can get FDA approved in children. And of course, there is this collaboration with the epilepsy department and the pediatrician to manage ongoing medication management and side effect management based on what the patient's therapies are. When it comes to emergency management, it's important for the pediatrician and the school to note that there should be an emergency plan for this child. We have most seizures kind of stop by about 2 to 3 minutes. If the seizure does not stop within 5 minutes, there is less likely chance that it's going to stop on its own. The new definition, previously the definition of status epilepticus was 30 minutes of seizure activity. Now we've realized that earlier we stop the seizure, the less morbidity is there from status epilepticus. So our seizure action plan states that if a seizure is greater than 5 minutes, it's a convulsive seizure that is greater than 5 minutes in duration, to administer emergency benzodiazepine. It can be in the form of Diastat, which is a rectal benzodiazepine, intranasal midazolam, or intranasal diazepam. In patients who have seizure clusters, and if they have more than 3 clusters or 5 clusters, depending on their baseline frequency. We also give them a plan to stop these seizure clusters from happening. In terms of a febrile illness or around immunization, because fever can lower the seizure threshold, we can also offer oral disintegrating clonazepam for a 2 to 3 day course during the course of illness to prevent increase or ramp up of seizures. Just to give you an idea of the number of medications that are currently in use, we have close to, I think, now 32, out of which maybe 30 are approved in children. We're still waiting for a couple. Some of these are specialty. For example, everolimus, fenfluramine. These are used in specific syndromes. Everolimus in tuberous sclerosis, fenfluramine in Dravet syndrome. So we are now moving closer towards, more precision medicine and precision and syndromic use of medication. The medications that you may have commonly heard are ethosuximide for the treatment of childhood absence epilepsy, which is one of the safest medications we've used and has a very narrow therapeutic index. It's only used for childhood absence epilepsy. Phenobarbital, which has been probably the favorite and well studied medication in epilepsy. We've also now started to use levetiracetam or Keppra, which is one of the more commonly used medications in epilepsy these days. And the other medications we know are oxcarbazepine, trileptal, valproate or Depakote, clobazam or Onfi. These are the ones that we've used more frequently in the treatment of epilepsy. So we have to think about the morbidity and the mortality of epilepsy. Yes, treating with medications is fantastic. We get very good treatment with our first medication that we choose. If we get really good results, and we're very happy. But we also have to think about the side effect profiles of these medications that we're using and the additive effects of medications should we use 2 or more medications together. In terms of the larger or the more scarier side effects of having epilepsy or living with epilepsy, things that will come up in discussion are, of course, status epilepticus, like we spoke about, and emergency room visits, as well as intubations related to medications used for cessation of status epilepticus. Of late, because of the death of the Disney star, SUDEP, or sudden unexplained death in epilepsy, became a mainstream discussion. There is a risk of death in epilepsy, more so in patients with uncontrolled epilepsy, nocturnal seizures, and uncontrolled generalized convulsive seizures. So this is something that we discuss with families and make them aware that it's not a benign condition. Of course, the cognitive and the developmental toll of children who have epilepsy is immense. There is a concern of drowning during so we have lifestyle restrictions for families. We say no, and of course in adults, a lack of independence because driving is not permitted in patients with active epilepsy. So there is a lifestyle restriction in children. That's also a confidence and peer interaction issue, given the restrictions that we apply. Also, in terms of disability, loss of work, loss of days at school, it's a big issue in children and families with epilepsy, especially if the families need to take time off for their child's appointments and for their child's admissions in the hospital. More importantly, we've also seen a lot of comorbid psychological impairments, comorbid mood disorders, and definitely a lot of social impairments in families with children with epilepsy. Specific mention that we've seen a lot of marital issues in families. We've seen a lot of financial burden, and we've also seen effects on normally functioning siblings who witness their siblings having seizures. So it's important to note that it's not just the epilepsy we treat, but it's also all the trappings that come with having epilepsy. So to conclude my talk, might be a little over time, but to conclude my talk, it's a complex condition with significant morbidity and mortality. Identifying seizures, seizure disorder, whether it's provoked or unprovoked, whether it is really epilepsy or not, is really important, and a good history and exam with a referral to specialized care is recommended early to guide therapy. Drug-resistant epilepsy is a failure of 2 or more anti-epileptic agents, and this should prompt further evaluation, even for epilepsy surgery, as an option. Again, a strong alliance with a pediatrician and a neurologist is essential, because it's not just the epilepsy, it's also all the other things that come with epilepsy management that will lead to a best outcome in patients and their families. These are some useful websites. The videos are from ILAE. They are from epilepsydiagnosis.org. They are free for use. I think for the videos you may have to log in, but for the description of seizures and the classification is free, and they have good explanations for seizure syndromes. Epilepsyfoundation.org is a very comprehensive website for parents and for caregivers and for patients. Danny Did Foundation is also when we talk about SUDEP, they have a very good website that talks about SUDEP and resources and devices for families to use. And cureepilepsy.org is more geared on the recent research and the recent updates in literature based on a comprehensive systematic information available at the current time. And they also offer very interesting programs for families with epilepsy. Thank you. See if I can.
That was great. Thank you so much. Really appreciate. I know it was a lot of information in a short amount of time, and I know you would love to have some more time with our folks. But for our folks online, we also know that you guys are awfully busy in your offices these days, so we understand that you need to get back. But we just wanted to thank Dr. Tatachar for joining us today. If there's any questions, I hope you'd type them in. If there's any questions, you can raise your hand or type them in the chat room there, you'll see, and we'll be happy to answer those for you. In the meantime, while you're typing those up, we just want to let you know that Dr. Tatachar sees patients at the main hospital, and she also does telemedicine visits. Would you like to expand on anything about that, about where you're seeing patients and how to contact you?
Yes, so I see patients at Lurie, which is the main hospital. I see mostly patients with tuberous sclerosis, like I mentioned. That's the area of focus, and for patients who have intractable epilepsy. We also do offer telemedicine for either of these sets of patients, and we can reach out either via calling the epilepsy center or via a referral from the pediatrician to the epilepsy center, which is, I think, on our website. The phone number is on the website to call to make an appointment for that.
Great. One question did come in. If a recurrent febrile seizure more than 4 in 6 months, does it need a referral? Looks like they amended that by saying 18 months old.
If it's a recurrent febrile seizure and there is a family history of afebrile seizures or epilepsy, that is 2 out of the 3 risk factors, then yes, they would need a referral to make sure there is no other genetic conditions going on. For example, there's GEFS plus or genetic epilepsy, febrile seizures plus syndrome. They have family members who are affected with epilepsy, with migraines, and with other movement disorders, episodic ataxia. So it would be good to to make sure if the child is otherwise developing normally, it's unlikely that they have any other issue because the child has still up until 6 years and they can continue to have recurrent seizures if they have the susceptibility to it.
Well, thank you for that. It doesn't look like there are any other questions that are come in. So, and we got to end the presentation now. So I just want to remind everybody that we'll be back on at 9 a.m. with Dr. McDonough. She'll be talking about infantile spasms in our spasms clinic. And at 12 o'clock, we're going to be having Chris Mascos, our lead tech for neurodiagnostics, and Eric Padilla, director of diagnostics for the Epilepsy Center. They'll be talking about EEGs. At 3 o'clock, we'll have Robin Blackford talking about the ketogenic diet. And Dr. Joyce Wu will be on at 5 p.m. talking to you about epilepsy surgery. And again, thank you for joining us, and I hope to see you in an hour or so. Be well, everybody, and take care.
Thank you.
Thank you.